Welcome to the recent approvals episode of the ASCO University Weekly Podcast. My name is Alex Konetsky. I'm a clinical pharmacy specialist in the Hematologic Malignancies Blood and Marrow Transplant Program at the Hospital of the University of Pennsylvania. Today we will discuss the approval of blinatumomab for the treatment of adult and pediatric patients with B-cell precursor acute lymphoblastic leukemia in first or second complete remission with minimal residual disease greater than or equal to 0.1%. As a background to today's discussion, the strongest predictor of long-term outcomes in B-cell ALL is the presence of minimal residual disease in the bone marrow despite intensive multi-agent chemotherapy. This is particularly noteworthy as MRD is detectable in 30 to 50% of all adult ALL patients and in another 10 to 20% of pediatric ALL patients that are in a morphologic complete remission. Consequently, there's a significant need to identify novel strategies to improve outcomes for patients with ALL with detectable MRD. As MRD results from persistence of leukemia cells despite multi-agent chemotherapy, utilizing agents with alternative mechanisms of action may be particularly beneficial. One promising approach has focused on utilizing blinatumomab, which is a bispecific T-cell engager that directs T-cells to CD19 positive cells already approved for the treatment of relapsed refractory B-cell ALL. On March 29th of 2018, blinatumomab was approved by the FDA for the treatment of adult and pediatric patients with B-cell precursor ALL who are in remission but still have minimal residual disease. The approval of blinatumomab for MRD-positive ALL was based on the results of the BLAST trial, which was published in Blood. This was an open-label, single-arm Phase 2 study in patients with B-cell precursor ALL in first or later hematologic complete remission, but with persistent or recurrent MRD after a minimum of 3 blocks of intensive chemotherapy, and MRD was defined as greater than or equal to 10 to the minus 3. Patients received blinatumomab at a dose of 15 micrograms per meter squared per day by continuous infusion for up to 4 cycles. Each cycle comprised 4 weeks of blinatumomab followed by a 2-week treatment-free period. Patients could undergo a stem cell transplant at any time after cycle 1 at the investigator's discretion. Prophylaxis for central nervous system ALL was recommended before cycle 1 and after cycles 2 and 4. Corticosteroid pretreatment for prophylaxis of neurologic events as well as cytokine release syndrome was required. The primary endpoint was the rate of complete MRD response after cycle 1. Of 113 patients with evaluable MRD markers, 88 achieved a complete MRD response after cycle 1, which translated to a 78% MRD response rate, so 78% of patients achieved the primary endpoint. Median relapse-free survival and overall survival without censoring at transplant and post-blinatumomab therapy were 18.9 and 36.5 months respectively. Both relapse-free survival and overall survival were significantly improved in MRD responders versus those who did not respond. In addition, both RFS and OS were significantly improved when blinatumomab was administered in first CR compared with later CR. With respect to the adverse event profile, 3% of patients had cytokine release syndrome of any grade, and 53% of patients had a neurologic event of any grade. The approval of blinatumomab as a treatment for MRD-positive B-cell ALL marks a significant advance in the treatment of patients with this disease, as this is the first FDA-approved therapy for MRD-positive ALL. As ALL patients with MRD have a higher propensity to relapse, utilizing a treatment to eliminate any remaining disease may keep the leukemia in remission longer. It's important to keep in mind that blinatumomab's approval for MRD-positive ALL was granted under the accelerated approval pathway, and full approval is contingent upon confirmatory results from future studies. In addition, the role of transplant after MRD clearance in B-cell ALL remains unclear, as the study was not designed to answer such a question. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on immune therapy and the treatment of acute lymphoblastic leukemia, please visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.